Good afternoon. I'm David Luberoff, Deputy Director of the Joint Center for Housing Studies, and it's my pleasure to welcome you to today's talk on whether affordable housing policies can reduce health disparities. This is the last event of 2023, but we're already planning for 2024. In January, we'll be releasing our biannual report on America's rental housing, and that'll be followed by events throughout the winter and spring on a variety of subjects, including what we can learn from recent studies of homelessness in California, the geography of pandemic-era changes in home prices, and the ways that manufactured housing might help address the housing affordability crisis. Information about those is not yet posted, but keep your eye on our website and look for our emails after the new year when we'll be announcing all of that. Now on to today's presentation, which features Noémie Sportiche, who received her PhD in health policy from Harvard last spring and is now a researcher at Mathematica. Noémie is going to be discussing research examining the health impacts of housing policies that focus on desegregating affluent, largely white suburbs. While those of us in the housing field have paid a lot of attention over the years to these policies, the health effects is not something that has gotten a lot of attention, at least until Noémie came into the field. Recognizing the importance and significance of her work, last spring, the center awarded her its annual prize for the best student paper on housing. She'll be discussing that paper in today's talk, and that paper is also available on the center's website. Noémie's going to talk for about 35 or 40 minutes, followed by Q&A. You can submit questions using Zoom's Q&A feature. Apologies in advance if we don't get to your questions, which we will share with Noémie, and she may follow up with you. We'll end at about 1:15 p.m., and we'll have video and the slides from today's talk posted by early next week. Noémie, it's all yours.
Thank you, David. Let me go ahead and share my slides. Great. If folks cannot see my slides, someone please let me know. Otherwise, I will assume everyone can see what I've got up here. So I'll just go ahead and get started. Thank you for the introduction, David, and thank you to everyone for being here today. I'm excited to talk to you about this paper, and I'm very curious to hear what questions you might have at the end of the presentation. So like David mentioned, what I'm going to do in this paper is basically try to evaluate the impact of a major desegregating housing policy, Chapter 40B, on health outcomes. And in particular, I'm going to focus on the health outcomes of newborn infants and their pregnant parents. So, there's obviously a lot of reasons to care about desegregation, but the reason that I, as a health policy researcher, am focusing on this question is that, despite a state-of-the-art health system, the US performs pretty poorly on a wide range of health outcomes and has pretty large disparities across many of those outcomes that persist, despite substantial government interventions aimed explicitly at reducing these. So, the health system has been trying to figure out how to actually how to move forward from here. And one potential explanation that has gained quite a bit of traction is that it's something else, like the disparities in the conditions and the neighborhood environments where people are living, that are actually driving some of these poor health outcomes and health disparities. So, it's going to come as no surprise to the folks on this call that we know US neighborhoods are really segregated, both by race and by income. And there's this large and robust literature showing that many of the kind of characteristics of where we live, like the quality of the air we breathe, different aspects of our neighborhoods that might cause or alleviate stress, educational opportunities and things like that, will actually affect health and well-being throughout the life course. So this implies, in turn, that housing policies that actually aim to desegregate by race and income and reduce neighborhood disparities along these dimensions could actually improve health and reduce health disparities. So naturally, that's the motivation for this paper. And what's perhaps a little bit surprising, or at least was to me, given how broad of a motivation this is that there's very little research on this topic. And I think one of the reasons that's the case is that it's actually very difficult to desegregate by race and income in practice. So, one of the major tools that we use in the United States to facilitate upwardly mobile relocations are housing choice vouchers. And these are actually what a lot of the evidence about neighborhood health effects are based on. But in practice, for a really wide variety of reasons, housing choice vouchers kind of struggle to facilitate as upwardly mobile of moves as we would like. So, like I said, there's a lot of reasons why this might be the case, but the one that I'm going to focus on in this paper is that zoning regulations, which govern what we can build where, are used by the wealthy white areas that might be the target of some of these housing choice voucher efforts and the moving to opportunity demonstration, specifically to limit the supply of affordable and lower cost and even just market rate rental housing in these areas. So this implies that if we don't deal with some of these supply side regulations, that we have a ceiling kind of on how much we can desegregate by race and income. So that's what makes Mass Chapter 40B pretty interesting in this context, which has been around for quite a long time. And some of you on this call may know, maybe everyone on this call will know about this policy. But I know about it actually because prior to getting my PhD, I was an urban planner for the state of Massachusetts at the Metropolitan Area Planning Council. And I think there are two aspects of this policy that are quite interesting in the context of health and health disparities. So the first is that the policy's goal actually kind of aims specifically to address some of the issues that I just raised. So 40B aims to desegregate by both race and income by mandating that all municipalities maintain some minimum share of their housing as affordable. And importantly, it allows developers to bypass some of the zoning regulations I mentioned when municipalities don't meet that minimum fair share, which in Massachusetts, the most kind of commonly enforced standard is 10% of housing being affordable. Now, you'll notice throughout the presentation, I'm really going to focus on the income component of this policy, but there are components of the policy that aim explicitly to desegregate by race, which we can discuss if folks are interested at the end of the call. So the second reason that 40B is a really interesting policy in this context is that it's just really important in Massachusetts. It's directly permitted almost a quarter of the affordable housing in the state, and it served as a model for many other states, both historically and most recently was actually part of the discussion about how to deal with some of California's housing crisis. So it remains pretty policy relevant today. It's not a priori clear, and I'm not really talking about the mechanisms behind this here or the reasons for this, excuse me, but that 40B would build housing in these high income, wealthy, kind of whiter areas. But actually in related work, my colleagues and I show that it does. So if we look at where affordable 40B units are located, the neighborhoods have very different types of characteristics than the neighborhoods in Massachusetts that are available to, both project-based and mobile housing choice voucher recipients, and then LIHTC beneficiaries and public housing beneficiaries as well. So, this all implies that there's potentially something promising about 40B from a health and health disparities perspective. So despite all of this, again, to the best of my knowledge, there's no prior research has really evaluated the impact of moving to 40B on any kind of outcomes of the program's beneficiaries. And the reason this is the case is that actually we haven't had the data available to do this, which is an issue that we solve in that related paper, and I'll discuss more later on in this presentation. Now making it possible for me, for instance, to answer questions like in this paper: how has access to 40B housing affected the health outcomes of the program's beneficiaries? And in particular, like I said, I'm going to focus on birth outcomes, the health of the pregnant parents who gave birth, and their healthcare access during pregnancy and at birth. And then I'm also going to the extent to which I find any evidence of health effects, try to understand what mechanisms might be driving those. So the time period I'm going to focus on is between 2000 and 2019, which is when the bulk of 40B developments were built. And just to preview my results, my main finding, which is what I'm really going to discuss in this presentation, is that I find among a subset of the beneficiaries of this program, birth outcomes actually improve a lot. And then when I try to understand what mechanisms might be driving those effects, my evidence shows that it's a combination of the fact that 40B facilitates relocations to more upwardly mobile neighborhoods, and also that birthing parents' health behaviors during pregnancy change. Okay, so I'm just going to give you a little bit more background about 40B before I dive into what I actually did in this paper. So focusing only on the buildings that were permitted via a 40B comprehensive permit, there are about 57,000 total homes, and 18,000 of those are affordable that have been permitted through 40B. And then the basic process by which a 40B development is built is that a developer will build many homes at once in a single development, where then, like many other processes, each development then mixes market rate and affordable units, where the typical development actually has about 25% of those units being affordable. Then those developments can range in size, and they can be either rental or ownership, which is a kind of unusual aspect of this policy. So just to kind of show you what actual 40B developments look like, this is a pretty typical example of 40B rental development and a 40B ownership development, where these ownership developments are often kind of suburban sort of cul-de-sac type of developments. Okay, so many of you are probably wondering what I mean by affordable. So an important difference between 40B and some of our other major affordable housing programs is that it's designed to serve a broader range of incomes. So most units are going to be subsidized at the 80% of area median income standard, where at the midpoint of my study, a 2-person household would have qualified for one of these units in the rental program if they made under the maximum threshold listed here. It's also possible to layer 40B with other programs. So, and in particular, we hear anecdotally that it's layered with vouchers frequently, but we actually don't know empirically the extent to which that's actually the case. Then the ownership program kind of most simply functions by restricting the resale price of the property, making it not possible to essentially accumulate wealth through the 40B ownership program. And the basic way that the price is restricted is that it is maintained as what's considered affordable for a household earning at 70 to 80% of AMI if they were paying 5% down for the home, where the mortgage would be 30% of their monthly income. Okay. All right, so the last thing I'm going to tell you about 40B is how people become 40B residents. So the basic process is that, toward the end of when a development is built or after it's built, the law mandates that affordable homes be affirmatively advertised broadly toward those who federal civil rights law dictates are least likely to apply. So these are federally protected classes based on race, color, gender identity, disability, et cetera, and also toward lower income residents who are not from the municipality. And then during that same 60-day period, potential residents apply for an affordable housing lottery, which is allocated at the household level. Then the lottery is conducted. And then here I'm showing that everyone who is top ranked in the lottery will move into the units. So there's a few different ways we might study the impact then of this program on beneficiaries' outcomes. And the one that I'm going to focus on in this paper is I'm going to focus on the residents that I observe moving into 40B developments. And I'm going to compare how their health outcomes change over time to a plausible comparison group. And the way that I'm going to do that really comes down to the data that I have available. And so I'm going to use 3 kind of core data sets that are going to allow me to anonymously identify who 40B beneficiaries are, track the characteristics of their neighborhoods over time, and then observe their health outcomes. So I have 2 kind of backbone data sets that are going to really let me do this. And the first is the one that I hinted at earlier, which is a data set that my co-authors and I make available in that related paper I mentioned, which is a data set of the addresses of 40B developments, 40B buildings really, based on the Massachusetts Subsidized Housing Inventory, which is a public data set used to monitor compliance with 40B, which kind of has had some limited utility in past research because it doesn't contain complete addresses or correct addresses for many of the 40B developments that have been built through the policy. So what we do is we recover the precise geocoded addresses in this new data set that's going to hopefully be made publicly available soon, now making it possible to study kind of the detailed locational characteristics and also the impact on program beneficiaries for the first time. So these data also contain some other information that are about developments that are quite useful, like the tenure of the development and then permit filing dates, things like that. So that's my first kind of core data set. Then the second data set is a data set of people, which is based on consumer reference data that contains the entire history of addresses for all adults who've lived in Massachusetts roughly since 1980. So basically what this data set contains is kind of the sequence of addresses where people have lived both within and outside of Massachusetts. And because it contains those precise addresses with the times when people have moved in and out of those addresses, I leverage that fact to identify whether a particular address in that data set of individuals is a 40B address. And that then allows me to create a data set of people who become 40B beneficiaries at some point during my time period, including the places that they moved into those 40B developments from, and then a data set of people who never become 40B beneficiaries during my same time period. And then finally, I leverage a few additional components of this data set to link people to their Massachusetts birth records during roughly the same time period. And for those of you who are not familiar with this, all of my final data has to be fully anonymized for IRB compliance reasons. Okay, and then these health records contain a really rich amount of information just on all different kinds of health outcomes, but also health and birth histories, insurance coverage, and characteristics about the people who are actually giving birth at the end of this period. Okay, so that then allows me to create this final data set, which is a data set that is just focused on those people I observed giving birth during my time period, where about 3,000 of them become 40B beneficiaries at some point. Some will give birth before they move in, some after. And then about 300,000 are people who never become 40B beneficiaries, but I also observed them giving birth in Massachusetts during this time. Okay, and I just want to flag before I move on that these data are pretty cool in the context of health research because they contain self-reported race ethnicity data, which will allow me to look at racial disparities, which is very difficult to do with health records typically. So I'll talk more about that in just a little bit. All right, so how do I actually do this? Well, my basic strategy is to use what's called a difference in differences design, where fundamentally what I'm doing is I'm comparing how health outcomes change over time in a group of treated 40B beneficiaries, so these people I observe giving birth and moving into 40B developments, versus a matched control group. What do I mean? So I mentioned I have this really rich data set that allows me to kind of see the different types of neighborhoods that people are moving into over time. And I leverage that fact to find the neighborhoods that people move into 40B developments from, to compare them then to a group of other similar, demographically similar people, so of similar race, ethnicity, a similar age, who also moved in a similar year from similar neighborhoods, but somewhere other than 40B. So stated another way, I'm comparing the health outcomes over time of two groups where both of them move from similar types of neighborhoods, one of them moves to 40B and the other group moves anywhere else. Okay, so the key assumption I want you to keep in your minds while I'm talking about this that makes this a plausible comparison is that in the absence of 40B, the health outcomes of my treated 40B beneficiaries would have kind of changed in the same way as this control group had they not moved to 40B. All right, so then very briefly, statistically, how I estimate the effects. I basically run two separate sets of models for renters and owners because both the developments themselves and the selection into each type of development is really different. Where my first study is what's called an event study, where basically I'm looking at the year-to-year differences over a 10-year period. And I omit the year prior to the move in the comparison. And you don't really need to understand a ton about this, except that I have about 3,000 treated 40B beneficiaries And that is a decent sample size, but it's not quite enough to have enough statistical power to run this kind of model. But this model is nevertheless important to figure out, to make sure that it's reasonable for me to run this second set of models, which is what I'm really going to present to you. Most of what my findings are going to be based on, which is essentially the same model, but I pool those 5 pre-years before people move into 40B and 5 years after they move out of 40B to gain more statistical power. So if you didn't follow any of this, that's okay. It should be clear in the results anyway. All right, so what do I find? So like I mentioned earlier, I find that among a subset of the beneficiaries of this program, the 40B renters, there are these large positive improvements in birth outcomes. Interestingly, I don't find any evidence of effects among the owners of this program, but I'm not going to talk too much about that in the presentation, although we can talk about it in the question and answer session if folks are interested. So to give you a sense of how I came to the conclusions in this table, I'm going to walk through how I came to the conclusion that there are these large positive effects on birth outcomes among 40B renters. So if we plot the results of that first statistical model, where here each plotted point is going to represent the average change in birth weight between the period K, so relative to the move, and the period 1 year prior to the move for my treated 40B beneficiaries relative to my matched control group who moved somewhere else from the same origin neighborhoods, you can see here that I'm not finding a huge amount of evidence that there's an effect. And you can see that because the standard errors overlap with 0. But you can also see, like I mentioned, that I don't have a lot of statistical power. So here, the standard errors are roughly the size of that are roughly equivalent to 10% of a healthy infant's weight at birth. So they're pretty huge. But again, this model is valuable because it allows me to see that there's kind of no real evidence that these points trend consistently upward or downward prior to when people move, which suggests I can pool the pre-move years. And I don't see a lot of evidence that treatment affects kind of very systematically over time once both groups have moved. So again, this means I can run that second model with some confidence. All right, so if we then plot the results of that second model, here's what they look like, where here each plotted point represents the standardized coefficient, since each variable here is on a different scale for the outcome in that row. And the way that you want to interpret this is that each point is going to show you the additional effect of moving to 40B housing on that outcome. So for instance, here, what you're seeing is that for 40B beneficiaries, after they move to 40B, they have babies that are 74 grams heavier on average than people who move elsewhere after they move, okay? So as you can see here, now that I've pulled these results, you see improvements across many birth outcomes. But it's possible that this is not actually being driven by the program. So the first thing to kind of check is if that's the case. We call this selection. And basically, what I want to test here is make sure that, I'm really comparing a plausible comparison group to my 40B beneficiaries, because, for instance, perhaps they're just not as healthy. And so what I'm actually detecting is the effect that these are not comparable groups, but not actually an effect of moving to 40B. So if we look at some things that shouldn't be affected by the move, but might give us some sense of that, like chronic conditions or previous birth histories that occurred prior to prior to the birth that I'm studying in this case, I don't see really any differences across these groups. So this suggests actually that from at least a health perspective, these groups are pretty comparable to each other. We also might be concerned that, the Great Recession occurred during this time period. Maybe 40B beneficiaries are more likely to experience some kind of economic shock, which leads to them moving into a 40B development, and that could also affect health outcomes. But encouragingly, I don't actually see that they're more likely to become Medicaid beneficiaries. There's kind of no difference in the two groups on this, which again is encouraging for from the perspective of comparing these two groups as a plausible comparison. All right, So then the next question is to ask is, well, okay, how substantively large are these effects? How meaningful are they? So one way to do that is to compare, for instance, this 2% increase in birth weight to something known to affect birth weight, such as the effect of smoking. If I do that, I can actually see that the magnitude of this effect is quite large. So it's about 30 to 50% of the effect of smoking on birth weight, which is pretty huge and unusual for a social policy. Similarly, this is kind of true for other outcomes like preterm birth. So this 33% reduction, which is where PP here is a percentage point reduction, is roughly the same magnitude as smoking. So again, very, very large effects. Some of you also may notice that there are relatively wide confidence intervals around this. But even at the lower bound of these estimates, actually the effect of the program is on par with other social policies like receiving SNAP benefits, for instance. So pretty meaningful effects. All right. Next, I ask whether effects vary across racial ethnic groups, and I find that they do, actually. They're driven primarily by white and Black non-Hispanic beneficiaries, where encouragingly, actually, the effects are largest among Black non-Hispanic beneficiaries, where, for instance, the effects on birth weight are about 6 to almost 8 times larger for this group. And that pattern persists across the other outcomes, although the effects are a little bit more attenuated. Okay, and then finally, I wanted to make sure these results are not spurious, so I do a whole variety of things like constructing other control groups, testing outcomes that shouldn't be affected, shifting the move year to a year where people didn't actually move, where you should find no effect, and I do. So this all suggests that what I'm finding here is really an effective 40B, and it is not a spurious effect. All right. So I mentioned that these are the main finding is that there are these large positive improvements in birth outcomes. And I think the kind of most interesting part of any policy analysis is then what might be driving these effects, because that's where the policy implications come in. So there are a number of different kinds of pathways that might explain some of these effects in this case. So like I mentioned, one of the core motivations for why I got involved in this particular project is that it might be the case that 40B is facilitating these relocations to new neighborhoods that could then affect a whole variety of different aspects of people's neighborhoods that then in turn affect health outcomes. So for instance, exposure to pollution, which birth outcomes are very sensitive to, changes in access to medical care, changes in perceived safety, which could affect stress outcomes, et cetera. But this is not the only potential pathway through which something like 40B could affect birth outcomes. The program is also, by being an affordable housing program, it may be the case that people are actually just paying less for rent than they otherwise would be, and that those additional material resources can then be used to either get better access to prenatal care or other improved material resources like healthier food, for instance, which could improve birth outcomes. There may also be something about, once you get into a program like this, it may be more stable, the housing may be more stable, it may be more secure, and that may also affect things like continuity of care, stress levels and material resources, which could in turn also affect health. And then, birthing parents' behaviors could change as well. So for instance, you might actually move to a building where now smoking is banned. And that could actually affect, how much you smoke during pregnancy, which definitely would affect birth outcomes. All right, so let's actually dive into some of these and try to understand what might be driving these effects. So like I mentioned, the core motivation is really to see whether 40B facilitates these relocations to new neighborhood environments. But in order to actually understand whether that might be driving health effects, first it needs to actually facilitate those upwardly mobile moves. And I'm going to show you that it does. So if we begin by just plotting here the neighborhood level poverty rate for the neighborhoods that people move from on the x-axis to the neighborhoods that people move to on the y-axis, where higher points means moving to a higher poverty area after you've moved, and lower points means moving to a lower poverty area, we can pretty clearly see that across the board, 40B beneficiaries are moving to lower poverty areas than my comparison group is. and that these differences also persist across a wide range of other outcomes. So 40B beneficiaries are moving to wider, higher income neighborhoods that have lower pollution exposure, where UFP are ultrafine particulates, and also better outcomes for social mobility for children based on opportunity insights measures. So, the other kind of key thing here would be that if health effects are really being driven by neighborhood relocations, then we would expect to see larger health effects for people who see larger differences in neighborhood relocations, and also vice versa, that health effects would be driven by people who see those biggest changes. And that is indeed what we see. So first, the changes in neighborhoods are just much larger for Black beneficiaries than they are for white beneficiaries, where some of these differences are pretty massive in the types of neighborhoods that people are moving to. And health effects are also driven by the beneficiaries who are moving from these types of areas that I've listed here. So higher poverty, higher male incarceration areas with more Black residents. So this will suggest that there's some evidence that actually 40B, the health effects for these renters is really coming from the fact that 40B is facilitating these neighborhood relocations. But again, like I said, there's these other potential mechanisms. So let's explore those. What about the housing subsidy? So, 40B is not like the housing choice voucher program. It doesn't provide a direct cash subsidy to individuals, but it implicitly does kind of lower the rental cost of their home, which via a back of the envelope calculation, I estimate to be roughly $260 per month. So drawing on this estimate and previous estimates of the effect of that quantity of money per month of food stamps on birth weight, that suggests birth weight would increase by 29 grams. So you can see that that's not the entirety of the estimate that I observed in this study. So that suggests that subsidy is only predicting part of the effect here. And moreover, if the subsidy were predicting the effect, then we would actually expect that effect to be replicated for other affordable housing programs. And so I test whether that's the case by actually replicating all of the analyses that you just saw me discuss for the beneficiaries of the Massachusetts LIHTC program. Now, LIHTC is obviously different than 40B, but it's a pretty natural comparison because it's the other major supply side housing program in Massachusetts, and it offers a more generous subsidy. So this again is just my back of the envelope calculation based on the maximum income thresholds allowable by LIHTC and 40B. And then it also is interesting because it cites housing in very different locations. So the darker red means more affordable units, where we can see here that 40B rental housing is located in these wealthy white suburbs, and LIHTC rental housing tends to be located in dense urban neighborhoods. So when I replicate all of these analyses for LIHTC, you can see that I don't find any effects on birth outcomes. And moreover, I showed you earlier that 40B facilitates moves to these lower poverty neighborhoods. Well, if I compare 40B beneficiaries directly to LIHTC beneficiaries, where these are two sets of people who move from the same neighborhoods, but one moves to 40B and the other moves to LIHTC, I can see that the difference in that poverty, the neighborhood level poverty, is even bigger, where there's, again, just a bigger delta in the neighborhood conditions that people are moving to. And if I run the statistical models, then comparing 40B to LIHTC, you can see now my standard errors have increased, but so too have the magnitude of the coefficients, which really suggests that there's something else going on here, and that it's not the housing subsidy, because we would expect to see that replicated for other programs if it were. And it's also kind of not something general about affordable housing, again, because I'm not finding this effect for LIHTC beneficiaries. So finally, I'm not going to talk about these in detail, but I do also find some evidence that smoking in particular mediates some of the effects on birth outcomes I find, especially among Black non-Hispanic beneficiaries on preterm birth. So this is also potentially important. And I'll note here that I can't distinguish between these, but it's possible that parental health behaviors are changing because people are moving. And so, it's a little bit tricky to figure out exactly what's going on there. But, that's sort of what the evidence suggests. So there are, of course, some limitations to this study. For instance, I can't observe the quality of the buildings that people are moving into, and that could definitely be driving some of the effect if people in 40B are moving to kind of nicer, newer buildings than the comparison group. And I also want to note that I can't distinguish in the rental program, I cannot distinguish between the affordable unit beneficiaries and the beneficiaries of market rate units based on how 40B is designed, because the affordable units are not fixed in a rental building. But I don't think that's a huge problem because there's actually quite very little market rate housing in these neighborhoods as well. And so I think just even if this effect is driven by market rate beneficiaries, I think it's still actually of substantive and policy and health policy interest. And then finally, of course, it would be valuable to expand the number of outcomes that we look at. All right, so I'm just going to wrap up with a very brief kind of note on some very high level policy implications, which just really begins with the fact that these findings really suggest that policies like 40B, which bypass exclusionary zoning, could potentially be useful for improving health and reducing health disparities, which is important because those of us on this call will know that this is a major policy priority right now. So dealing with exclusionary zoning and zoning reform, based in part on the fact that we know there are a lot of negative consequences to housing markets, segregation, equity and political processes, and more, based on actually some of these issues. And now we can also add that health may also be improved by bypassing some of this potentially. And then, the natural question to ask from this is 40B the right policy solution, which is something that maybe we'll discuss in the Q&A. And I don't think this study answers that question. Of course, there are potential trade-offs to this particular approach. And I think we need some more research on 40B, which my colleagues and I are actually working on right now. So for instance, my colleague Hector Blanco is leading some work right now trying to understand how the residents of the destination municipalities where 40B developments are built respond. So do they move out? Do they change their political voting behavior, their participation in future affordable housing meetings in response to these developments, which could obviously undermine future affordable housing development and the goals of this policy. And then we're also working with the Executive Office of Housing and Livable Communities, formerly DHCD, to actually collect the lottery data on 40B applicants, and then link those to health records, which of course will allow us to see who's even applying to these units and whether there are aspects of the policy that undermine some of its goals. And then finally, I'll just say there are other approaches to dealing with exclusionary zoning. And I think, of course, we need to understand the various health effects and other consequences for housing markets and other outcomes of these various approaches to try to understand what the trade-offs are and figure out what the right approach moving forward is. So I'll just end by thanking the much larger team of which this paper is part, and our funders, the Robert Wood Johnson Foundation, and the state partners with whom we've worked on this project, without whom really, honestly, this would just not be possible. So thank you very much to them, and I'll stop here and open it up for questions. Thanks so much.
No, I mean, thank you. It's really, I mean, I've obviously seen the research before, but every time I see it again, I'm just really struck by what you've been able to assemble and some of the powerful questions. Let me just start. There are a couple of clarifying questions that folks had, and I'd also encourage folks to continue to put questions in the Q&A. The affordability restrictions, somebody asked if these are time limited. So a lot of places it's a 20-year. Are these permanently affordable, or will these expire at some point in time?
Great question. So it's a mix. The vast majority are permanently affordable, but there are some that are expiring, and the timeframes for expiration vary. So I think it's a minimum of 15 years.
As a unit turns over, there's also some process for.
Yeah.
Just one other clarifying question. Somebody asked if the point on smoking cessation is, and I think you demonstrated this, is something that's actually good for both the person who stops smoking and also
Yes.
the newborn.
Yeah.
I'm going to take you up on an early offer, which is what I was struck when I read the original paper. I was struck when I listened to this, that you found these effects for renters, but not necessarily for owners. And what could you perhaps talk a little bit about both what you found, but also any thoughts on why?
Yeah, that's definitely something that I don't have a fully satisfactory answer to, but is, I think, very important. So I've explored a few different things. One natural question we might ask is there something different about either the ownership developments or where they're located that might actually, mean the rental developments have more promise for health? And that's not the case. They're very similar to each other. I mean, the developments themselves obviously look very different, but the types of locations where they are very, very similar to each other, at least quantitatively, that I can detect. Another potential explanation, which actually has a little bit more traction, which let me see if I have a slide on this, is that, here we go, is that owners are actually selected differently from renters. So they're more likely to be white. They're more likely to move from higher income neighborhoods. And I think most importantly, there's the difference if you look at the very bottom in Medicaid beneficiary proportion. I just think that they might be better off actually from a health perspective than 40B renters. And therefore they kind of stand to gain a little bit less. I have a much smaller sample of owners who are giving birth as well. So what might be happening too is that people might be moving into the 40B ownership units once they already have kids. That may be more likely, and there may be outcomes that are important there as well. But that's a great question.
That actually leads, somebody posed the question about whether you've looked at or whether you will be looking at health outcomes over time for some of those kids. So what do we know anything about adolescents, for example?
Yeah, that's a great question. And that's something we're exploring right now. So I mentioned that we're collecting the lottery data and working with EOHLC to do that. So as part of that, I don't think we'll be able to look at adolescents, but we are hoping to actually look at some kids' health outcomes using health claims data. And I think that, a lot of literature suggests both that neighborhoods are really important. The places where, we grew up are really important, not just for infants and for children. And that, health effects formed at that time have lifelong consequences, which are really important to understand from a public health perspective. So that's definitely something we want to do. So we're looking into that, but it's a little more challenging to get data on children than it is on adults.
Looks like we're getting several questions about whether there's a sort of self-selection bias here. So that, is there something about people who would be willing to move, really change neighborhoods in a significant way? And I guess, how have you thought about that? And it sounds like you might be trying to get at that in some of the new research.
Yeah, I mean, I think that's always, how plausible your comparison groups are always a threat with this kind of research. But the way I've tried to address that here, so recall in the comparison group, I'm comparing to people who also moved. So everyone's looking to make a change in this case. So I'm not comparing people who move to 40B to people who don't move, because I think that, again, the reasons we might move and make some kind of change are important. I also think, the comparison with different types of comparison groups, so lie-type beneficiaries, for instance, is also helpful in this case to try to get a sense of what that might look like. There are, of course, things that I don't observe about 40B beneficiaries. So for instance, maybe they're very good at getting opportunities for themselves. And then they're also better at seeking out, care for their infants, which would lead to better birth outcomes. But I think it's a little unlikely that I would be finding the effects I'm finding across the different comparison groups, if that's the case. Having said that, and I think, again, like I would see differences in birth histories and in chronic conditions. but yeah, I think the real key here will be to look forward to more studies. I think no matter how strong this one study is, I think we need many studies on this to really get a sense of how robust this finding is.
Yeah, I mean, it would seem like, I was thinking about some of the studies that people have done over the years on charter schools, that if you were able to somehow track the folks who applied for 40B but didn't get it, and ultimately, you know, what happened to them. But just staying on this point, there was a clarifying question about this comparison of 40B renters and LIHTC renters. LIHTC renters, I think, look like they have lower incomes, and that might, in part, does that potentially explain some of the differences you were seeing?
Yeah, potentially. I mean, so I think the way that unfortunately, I don't have pre-move income, because that would be the ideal thing to do, would be to just compare people who have the same pre-move income to each other who move to these different types of areas. But I think most likely my main comparison of people who are moving to 40B versus people who are moving elsewhere is comparing people who are a mixture of market rate beneficiaries and affordable beneficiaries to people who are actually maybe have slightly higher incomes who are moving elsewhere. And then the LIHTC comparison would be the opposite, so people who have slightly lower incomes. So again, the idea was to try to get different types of groups and see how consistently I'm getting the same results, knowing that the bias might be in opposite directions. Again, without the actual data on that, I don't know for sure, but given how the type of coverage in the data that I have, it's most likely, I think, that I'm comparing against higher income movers in the comparison group in my main analyses.
Mm-hmm. This is just a wonderful, wonderful set of questions here. Interesting question about whether you were able to look at and saw any kind of persistence over time. So, for example, there's probably a subset of people here who had a second kid. And I'm just wondering if were you able to probe at that, and what did you find?
I wasn't, mostly because of the sample size issue, because births are kind of a relatively rare occurrence. And so it's really tough to look at some of those questions. But I agree that there's, I think a lot of research in this area can sometimes focus on shorter term effects, but where, you know, longer term effects are really important. And that also might be somewhere where there's a difference between the renters and owners as well. And maybe the owners are also seeing, you know, benefits on a different time scale than the renters are. Hopefully we'll be able to kind of distinguish some of those things with future research. But yeah, I don't really have the statistical power to look in that great of detail here, unfortunately.
Yep. Going back, I was struck, you showed really interesting results for non-Hispanic whites and non-Hispanic Blacks. You didn't show us any results for Hispanic whites or Hispanic Blacks, and I'm just wondering if you can talk about that for a little bit.
Yeah, so I mean, Hispanic is a tough category because it is so heterogeneous, exactly like you're saying. So when I look at that group, they're a little bit of a perplexing group. They don't have consistent improvements in birth outcomes across any category, but they do have they do see large changes in neighborhood conditions. And it's not totally clear to me what's going on there, besides maybe actually there's a little bit of apples and oranges that are getting mixed together, exactly because it's such a large and heterogeneous group that I can't parse because I don't have enough statistical power to look into that. But yeah, I do talk about that some more in the paper because it is, I think, very important to think about. Asian households as well, also important to think about.
Yes.
But again, I it would be amazing if I could have like 3 times as many people, and then I could dive into some of these issues a little bit more closely.
Yep. Do you have any thoughts about the cost effectiveness of this policy? I was struck at one point, you said, you were comparing this to things like the CHIP program. So just wondering, is this look like, at least in the back of the envelope way, a cost effective way, if we were just thinking about it as health disparities?
Yeah, that's a great question.
I love the opportunity that I get to ask like ridiculously complicated questions.
Yeah, I mean, I mean, in all honesty, I haven't really done that calculation, but that is something that I would like to do, and I would like to also think about, if we were to generalize this and scale it, what would the potential benefit be? I mean, I think for sure, like, I don't actually know enough about how much some of the outcomes I'm looking at cost the health system. I think if we had more information on other health outcomes, and let's say we find that, this is really very promising for a wide range of health outcomes for, different age groups, then it could potentially be cost effective despite how expensive it is to build affordable housing, because it's expensive, because it's just the health system is so burdened by costs. And those costs are growing, and it's one of the reasons why there's so much investment in trying to figure out, how we can do better for people's health. Is that people are showing up in the health system too much. So I don't have a great answer for you. That was a wishy-washy answer, but I think it may not end up being cost effective, but that's, I think, not the right reason not to
Right.
pursue it, right? Because
Well,
there's obviously other reasons besides health to care about
yes,
affordable housing.
I think what's interesting about this is we've always thought that this was worth doing for a variety of reasons, and so any one of them, and again, it's striking findings. Did you find any other, again, just looking at this wonderful list of questions, any other significant differences, particularly by household composition? So I'm thinking of single parent or multi-generational households, or again, can you not tease that out enough from the data?
I cannot tease that out enough from the data. That is really something I would love to do, and I'm sure I'm missing people who I could be studying in this context, because the way that I've identified 40B beneficiaries, I sort of buried this, but I'm focusing on the birthing parent, because that's the only person I can be sure, right, is pregnant after moving to 40B in that new place. But it may be that, for instance, in a multi-generational or two-person household, that someone else is the person who's applying for the unit, and that then I'm missing some people who are part of this program. We're hoping to get household information and the lottery data, but it's really quite messy, because it's a privately administered lotteries by nonprofits, and each nonprofit has a slightly different way of recording the data and of changing those practices over time. And I think a lot of people don't input the household information in actual spreadsheets. So that's something we would really like, also for the outcomes for kids, but really tough to get there. I will say that anecdotally, we do hear that single parents are actually quite common, especially in the 40B ownership properties. And in some related work, we've also been, this is very early stages, but we've also been trying to look at whether 40B developments change anything about schools and school enrollment, which is also a big kind of subject of debate in the receiving municipalities. And we do see that there's an uptick in school enrollment after particularly larger developments are built. So suggesting, again, we are seeing people move with kids to
The
these
point
areas.
you're making about parents goes back to a note I'd made to myself, because I was trying to think about, you had something, what, 17,000 units created, and you were following 3,000 households, but that again is because what is it? You had to look for the keys under the lamppost where there was light, or something like that.
Yeah.
You went into this, particularly coming out of MAPC, having been, I think, steeped in discussions about 40B and steeped in the literature on health disparities as a major problem. I'm just wondering, were there any findings that particularly surprised you, either things you expected to find where the magnitude was much greater, or were there things that you expected to find that you actually didn't find?
That's a great question. Let me think about that for a minute. I think I would have expected I was surprised by the 40B owners finding, honestly. The sub From what we hear about the program, like there's a lot more demand for the ownership units than there is for the rental unit. I mean, I guess demand is really the wrong way to look at it because there are just many more rental units, but the ownership units, there are like much longer applicant lists for the ownership units. People really want to move into them, even though you can't accumulate wealth through those units. And there's something about ownership, it's like, it feels like it might be more stable than a rental unit. So you might imagine that would matter. And so I found that a little surprising, that there's not as much of an effect there. That's definitely something that surprised me. I'm sure I could come up with more things that surprised me. I mean, I'm also kind of frankly a little surprised that the policy works. And this is like building housing in these different types of neighborhoods, because it's so often the case that we are disappointed. So that's one of the reasons why I ran so many robustness checks, because I wanted to make sure that seemed legitimate.
Yeah, I think that early data was incredibly striking. As you noted, there are several states that are building on some version of this, and I'm wondering, if you were advising a state that was setting up a program and actually wanted to see if it was having the kinds of effects that you're thinking about, what would you? It's always easier to design these things from the start than, as you've been talking about, backfilling. So are there any either particular policies related to the program itself or to the tracking that you would commend people who aren't in Massachusetts to think about as they put a program like this in place?
Yeah, I mean, I obviously, as a researcher and someone who cares about like well-executed policy, I would say, please collect the data on the applicants so that we can see if the program is working and who it's reaching. But I think in terms of program design, one thing we haven't talked about yet is and that I think maybe we're moving more into in the housing space, but that's just tremendously important, is it's not just about where you build the housing, but it's also about who housing is serving. And I'm finding, that those health effects are not equally distributed across different groups. All right. So Black beneficiaries seem to benefit more, as do white non-Hispanic beneficiaries. And so I think really thinking carefully about, who is being served and how to reach those people, because that's also an open question that we're trying to figure out, is like, how do people find out about these 40B units? Do these affirmative marketing plans reach them? And, how are those executed in different by different nonprofit agencies who are running these lotteries? Because they do have different approaches, even though there are rules, they're kind of not as enforced as the minimum 10% standard is, for instance. So I guess the last thing would be like enforce it, because I think that's also why more development occurred after 2000, was because the state was basically like, we should be tracking this more and we should be enforcing it more. And so there was actually quite a bit of increase in a lot of wealthy municipalities in voluntary permitting through 40B, so that they could, I assume, retain control over the development process. But yeah, so those would be some of my notes.
40B is a law that by most rights should never have passed. Not on its merits, but on just its politics, and at least my understanding is it just came at this very kind of interesting moment, and the fact that it has proved to be so durable, including surviving a statewide referendum, and is still a relatively unique law, makes it particularly interesting. Well, I get the fun of reading the nominations for the best paper on housing prize, and when I first read this paper, I was just blown away, and I'm still blown away by the presentation, and it's really quite astonishing to me that this, as you noted at the end, is one of the first papers, if not the first piece of work, to take on what seems like a fundamentally important question. So I'm glad to hear that you're continuing to do this research. I look forward to reading it, reading about it and perhaps hosting you again. I hope everybody online will join me in thanking you for just a terrific, terrific presentation that was especially clear and compelling. So great work. Thank you very, very much.
Thank you, David, and to everyone who is still on the call.
Have a great day, everybody, and we'll see you in the new year with exciting programming. Thanks a lot.